I'm Claude Forget. I'm a member of the board, have been a member of the board, it seems forever, in the McGill University Health Center. And I'm chairman, founding chairman, I say this because it's been going for a long time, of the Committee on Quality and Risk. We've actually are in our 11th year of operation. So if you say, let's set up a committee on quality, there was very few dissenters. And I explained at the time, as I did to you, that we just had to shift some of our focus away from budget, finance, and structural issue, and focus on what our business really is to give care to patients and take responsibility for that. It's something that I learned through the experience of developing the final terms of reference, was that you have to accept that everybody involved in the healthcare field is well motivated to do the best they can, and that you cannot tell them how to do their job. I mean, the quality is something that they will bring to what they are doing, and it's something that has to be done with their active cooperation and trusting them that indeed their competence and their motivation is not in doubt. It's just that you have operating a very complex system in a teaching hospital in particular, and that the system itself may prevent them from doing what they would like to do. Now it's okay to say we can make mistakes. It was not okay in the past. I mean, of course, the reality was the same, but there was a culture of deference to professional and acceptance that what they did, well, was the best that could be done. Now we have a more critical attitude, and this is shared by the professionals themselves. They know how complex and difficult the decisions and the environment in which they work is, and they know there is room for error. And that has changed everything. You don't need to be a scientist to understand that quality is not some abstract science. It's a day-to-day reality, but looked at systematically, concretely, trying to put numbers. You know, there's a saying in management that if you can't measure it, it doesn't exist. And it's true for business, but it's true for the healthcare business as well. So quality is not mysterious. It's only mysterious in the abstract. You see, when you start dealing with an environment of professionals who now think it's acceptable to think about the possibility of errors, of incidents and accidents and adverse outcomes, you are then ready to move to the other step, which is to say, okay, if we encounter in delivering care a bad outcome or a bad process that could have adverse consequences, what do we do? Do we tell the patient, or do we keep it to ourselves? So our attitude has been, let's have a disclosure policy so that it becomes an obligation for professionals who notice that something has gone wrong. Each department has a quality committee to persuade them that this committee should be focused on quality, and it should be multidisciplinary. Pay attention to quality. How you do it, of course, very much depends on the local context, the size of the institution. I think, disclosure policy is one element, and in order to get there, you basically have to all sing from the same song sheet in terms of professionals and board, and understand that the board is ultimately responsible if there are mistakes. How can it be proactive in preventing them? The professionals have to understand that it's okay to, every human will make mistakes. It's okay to admit it and to disclose it to patient. So it establishes a dialogue between the board, the management, and the professionals, based on the basis of a shared responsibility and openness about it. If you're going to look systematically at performance and outcomes and process, you need to measure what you're talking about. Otherwise, you'll be exchanging opinions. I think we've done great things, but I mean, the challenge is really quite formidable, and it will never stop. I can't anticipate a day when the committee will say, well, we've done everything, so we can close up shop. So no, there's work for the future.